I will try to lead through imaging, and I only will concentrate on focal pancreatic masses and the usage of a new term which was coined and which is multiparametric EUS. So basically, you probably know the background. You know how endoscopy started, flexible endoscopy, some years ago. And you know the evolution of endoscopy reaching endomicroscopy. And you probably know that endoscopic ultrasound also had a similar evolution. You probably know this guy here. So everything started with the first fine needle aspiration procedure, and that led to a lot of developments in the field of FNA and also therapeutic procedures. However, we now have more imaging procedures, and the problem in focal pancreatic masses is like this. So most of them are hypoechoic. You can do a fine needle aspiration procedure. The accuracy is pretty good. So if you look at meta-analysis, then the sensitivity and specificity are higher than 90%. However, they are not 100%, so you won't get 100%. And then you have different solid pancreatic masses. So all of them are hypoechoic again. So if you look, this is an adenocarcinoma, this is a neuroendocrine tumor. So you need to use some other techniques, either Doppler or contrast enhancement or elastography to better characterize these masses. If you look at needles and fine needle aspiration, I don't want to go into details. This is a never-ending story. You don't know if bigger is better, if we should use 25, 22, 19 gauge needle, various techniques, but what we do know is, for example, the initial core biopsy needles were not better. So this was one of the studies which showed that they were comparable when you compare the same 22 gauge needles. However, we now have new and maybe better fine needle biopsy or fine needle aspiration biopsy, and they have a higher yield for histology. And everybody's pleased with these needles. The only problem is that the costs are quite high as compared to the usual needles. And also, we don't know much about the complication rate. So I think we should wait a bit and see what is the complication rate in really difficult patients with anticoagulant treatments and so on. So we do know that after FNA, we do have some complications which are minor and non-fatal. However, there are reported complications of about 1% after fine needle aspiration. So basically, I will try to briefly cover these techniques. So I'll start with elastography, so you know how it works. It works in real time. It's initiated by compressions. Usually you don't need to compress the tissues, you just need to keep the transducer still, and then the pulsations from the neighboring vessels will induce small compressions. You don't need to compress. The compression rate is very small. And then tumor tissues are usually hard, and they are hard to strain, and normal tissues are very soft. So this is the principle. I don't want to get into too many technical details. It's a very simple procedure. You just push a button. Usually the system should be set up, but you have to take care of a few things because otherwise the image quality won't be good. So first one is the size of the region of interest. If it's too small, then you get a lot of artifacts. So you need at least 50% of the elastography region of interest to be outside of your lesion. Then the degree of compression is also important. So if you look at the old system, you had a press indicator here. However, the new system have a strain graph display. So you have to look at the strain graph display, and there are two bars up and down. And this gives you an improved operator feedback. And you have to look at the strain rate display. So it should look sinusoidal. If it's if it's not uniform, then you should do something else. Either change the transducer position or look at the lesion in another way. And you should look at the elastography images during the decompression. So you can move back and forth your cursor, so you can look at various elastography images during a movie, and you should look during the decompression phase, not during the compression phase. And then you can quantify the information. So sometimes it's really difficult to look at the colors, so you can do either strain ratios or you can do strain histograms. So that gives you an impression of you get some numbers behind those colors. So maybe this is a bit more objective. The advantage of strain histograms is that you need only a small region of interest inside the tumor, so inside the larger elastography region of interest. You don't need two regions of interest. And then you probably know how the images look like, so sometimes they move quite fast. So what you need to do is to obtain the stable image. This is the pancreatic body visualized from the stomach, and you can average the images over several cycles. So you can record up to 4 cycles, I think, with the newer systems, and you can do an average image, and that will get rid of some artifacts. This again was normal pancreatic tissue, very soft, compressible. This was a chronic pancreatitis. So you see calcifications here, and you see it's a different appearance. It's a mosaic appearance. And if you look at the histogram, then the values are completely different. Then in patients with tumors, this is also different. So you get a hard, a stiff appearance of the tumor during elastography. And then if you look at the data published, this was our initial study. So in red, you see the patients with pancreatic adenocarcinoma. In blue, you see the patients with chronic pseudotumoral pancreatitis. And you see that there is an overlap. And our initial data showed a sensitivity and specificity of around 80%. So this is not perfect, and it's not going to be perfect. Although the systems on the market got better. So again, normal pancreas, chronic pancreatitis, and pancreatic adenocarcinoma. Again, if you have problem with the colors, you don't see very well, and it's very difficult to discern with the human eye in between light blue and green. So some of the colors are very difficult to be discerned. So then you do a histogram analysis, and you see that the values are smaller in pancreatic adenocarcinoma, and then the curve is skewed. So the standard deviation is smaller as compared to chronic pancreatitis, where the average value is higher and the curve is a bit more larger. So you get a larger standard deviation. So you can use the numbers. And if you look, there are a few meta-analyses in the literature. All of them include the same initial studies. So I think this is one field where the number of meta-analyses is probably higher than the number of published studies. So you get more than 1,000 patients in this one. You see very high sensitivity, low specificity. And this is valid in most of the studies. So basically, you cannot use elastography for the differential diagnosis. However, there are some important data that you can get, and this was a retrospective multicentric trial with several groups looking at very small pancreatic tumors, so less than 15 millimeters, more than 200 patients. And you see that actually when you have a soft lesion, then the negative predictive value was 98% for pancreatic adenocarcinoma. So in other words, if you have a lesion like this one, if you have a soft lesion on elastography, then you are pretty sure it's not pancreatic adenocarcinoma. This was a small insulinoma. This one was a small adenocarcinoma. The other way around, it's not really true. So if you have a hard lesion, a hard small lesion, then 50% of them were benign, 50% were malignant. But at least you can use this kind of information to guide your puncture, and that I will come back to this one. If you look at fancy techniques, this is 3D elastography in real time. It works with transabdominal transducer. It doesn't work with endoscopy transducers yet, although the cardiologists have better transducer which work in 3D in real time. I'm not sure if this is going to be helpful, so it falls probably in the category of technology in search for a disease. So we'll see if it's useful in the future, but maybe for virtual palpation that would be a nice way of doing things at the distance. If you look at the guidelines, the European Federation Societies of Ultrasound in Medicine and Biology published guidelines of elastography. This is a paper in press, so basically for endoscopic ultrasound, we know that it can be used as an additional tool for the diagnosis and grading of chronic pancreatitis. We know that it can be used as a complementary tool for characterization of solid pancreatic lesions, but it cannot differentiate pancreatic adenocarcinoma and chronic pseudotumoral pancreatitis. And then when you have a combination of elastography with contrast, which shows a hypoenhanced pancreatic mass, then even though you have a negative FNA, then you should either repeat the FNA or send the patient directly to surgery if it's resectable. So moving to contrast and Doppler technique, so you have to take into account the pancreatic vascularization. So this is entirely arterial. So then when you use contrast enhancement, you will have two phases, an early arterial phase, which lasts from 10 to 30 seconds, and then a late venous phase from 30 to 120 seconds. Of course, everybody uses Doppler, but in most of the cases you need to put some contrast because Doppler is not sensitive enough for very small vessels. So initially, when harmonic imaging was not on the market, we tried the usual power Doppler. So even if you don't have a high-end system, if you have a system only with Doppler, you can play with a bit of contrast. So again, this was chronic pseudotumoral pancreatitis. This was pancreatic adenocarcinoma. And this is also valid for CT. So the hypervascular masses are usually inflammatory, and the hypovascular masses are usually malignant. And this is an example. So a patient with a hypoechoic mass in the head of the pancreas, CT diagnosis oriented towards adenocarcinoma. And you see there aren't too many power Doppler signals inside. But if you put some contrast, and you don't need a whole vial. For Doppler, you need only 1 milliliter, maybe even less, so 0.5. Then you wait for 15 seconds, and you see a lot of vessels inside. You get a lot of artifacts as well, so you get a lot of blushing artifacts. You have to wait a bit, maybe decrease the gain in the system, and then you see that the mass was actually hypervascular. So this was a patient with chronic pancreatitis. If you look at a patient with pancreatic adenocarcinoma, this is completely different. So you inject contrast, you don't see any vessels with the power Doppler, maybe some vessels, collateral vessels here. But you inject contrast and you see that there is collateral circulation, but it's nothing much inside the tumor. So this tumor is hypovascular. And this is valid for most of the adenocarcinoma, not 100%, but most of them. And then you can also use contrast in other focal masses. This was a metastatic ocular melanoma. So he received a curative surgery 4 years before this mass was characterized initially by PET-CT. And you see that the power Doppler signals are again in the periphery. And this was confirmed as a metastatic melanoma in the pancreas with positive HMB45. However, there are some other masses. So this is, again, hypoechoic mass. You see the splenic artery in the splenic vein. Then after, you don't see too many power Doppler signals inside the mass. So after contrast, you see that this was actually hypervascular. So then, of course, you need tissue here. You need microhistology, and this was confirmed as a neuroendocrine tumor. So again, this helps you in maybe choosing the best needle. This was a bit peculiar because initially we thought it's a serous cystadenoma, so that's what the initial diagnosis was. However, the patient had 4 lesions like this in the pancreas, so from the head towards the body and tail. They were hypervascular, so they looked like a serous-cystadenoma, but the final diagnosis was lymphoma. So, and after treatment, they disappeared completely. So you have to be careful that not all the pancreatic masses are adenocarcinomas or chronic pancreatitis. But again, you get more information using Doppler and contrast enhancement. However, things progressed a bit, and the system nowadays allowed the use of contrast enhancement with harmonic imaging techniques. So this is how it's injected. So you inject it through the antecubital vein. You have to place it here directly, not perpendicularly, and you have to avoid the tubing because the anesthesiologists, they used a lot of tubes. So you have to avoid injecting the contrast 2 meters away from the vein, because all the contrast will be in the tubing. So you actually need to inject a whole vial. Sonoview is approved in Europe. You need to inject a whole vial directly, so 4.8 milliliters, and you have a lot of advantages as compared to power Doppler. So if you look at this case, a large hypovascular mass, but you see here the hepatic artery, and you actually see a bit of hypoechoic tissue on the other side. There's too much light in the room, but the resolution is very nice. It's impressive. It's even better than CT and MR. And you see that the artery here was completely encased in tumor tissue. And it's another example here. So you see a large mass, you see the celiac trunk, the bifurcation of the celiac trunk, and you see here the contrast, and you see that there is hypoechoic tissue on both sides of the celiac trunk. So this was again encased here at the origin of the bifurcation, and the hepatic artery was almost completely destroyed. So you see that there are some signals inside, but the mass is hypovascular, and you get more information about the staging. So this is how it works. I don't want to get into technical details, but basically the transducer emits with one frequency, and then it receives both the fundamental frequency and the second harmonic. It's like hitting a bell, and then you get some harmonics, several harmonics. You're interested in the second harmonic because the microbubbles are oscillating. So the idea is to use a low mechanical index. You don't want to destroy the bubbles. You just want to oscillate the microbubbles. And then what happens is that this is the grayscale image. So you see both the tissues and the vessels and the microbubbles. But what you want to do is to get rid of the tissue signal, and by using pulse inversion techniques or other kind of software techniques, you get rid of the tissue signal, and you see only the signal, only the second harmonic, so the signal returned by the microbubbles. And the advantage of Sonoview and contrast ultrasound agents is that they stay in the vessels. So what you see is actual vessels. It's not like CT or MR contrast which gets out of the vessel. So you have perfusion images. You see both the micro and the macro vasculature, and this is how it looks in a patient again with chronic pseudotumoral pancreatitis. So the pancreatic head was really inhomogeneous, a large mass. Then you inject the contrast and you follow the arterial phase and the venous phase, and you see that the mass was actually hyper-enhanced with a small cystic lesion here. So this was inflammatory. This was a chronic pseudotumoral pancreatitis, and you see that the enhancement persists also towards the venous phase. If you look at a patient with pancreatic adenocarcinoma, you see here the mesenteric vessels, but again, the tumor is enhanced, and you can look at the tumor in both the arterial phase and also the venous phase, and you see the hypoenhancement persists. Then if you look, you can also quantify this information. So you have a region of interest with yellow here inside the tumor, and a region of interest in red, which is in the normal pancreatic parenchyma. So you see this is the normal parenchyma, wash in, wash out, the normal curve of contrast in the normal pancreas, and the tumor is here in red. So the tumor was clearly hypoenhanced in comparison with the pancreatic parenchyma. This is completely different. So this was a lesion which was hypervascular. So you see it rapidly enhances, and you can see it a bit better as compared to the grayscale image. Maybe you don't see it better with grayscale, but you see it better with contrast. It's a hyper-enhanced lesion which is washing out pretty quick in the venous phase. So again, you can do time intensity curve analysis. This is inside the tumor this time. So this was hypervascular. This is the normal pancreatic parenchyma. So this is an example of a neuroendocrine tumor, and you can quantify this kind of information, and we did a multicentric trial with 5 centers, and you see that the numbers for sensitivity and specificity are higher than 90%, so the value is pretty good. This has been shown also in meta-analysis. So if you look at the numbers, again, sensitivity 94%, specificity 90%, with an area under the receiver operating curve of 97%. So it's pretty good. It performs, let's say, better than elastography. And you can also do it in 3D. So this is a tumor, again, invading the vessel here. And you can do it in 3D after contrast administration. And you see here celiac trunk, splenic artery, hepatic artery. So, and the tumor is here, hypoechoic. So it gives you a bit better image of the relationship with the major vessels. The most interesting is if you combine the two techniques. So if you have a hypovascular mass, which is hard on elastography, then more than 95% of them are adenocarcinomas. And if you want to look at the clinical impact, we did this retrospective study. So we looked in our database and we took all the patients with negative USFNA initially, and then usually in the patients, we do in all of them sequential elastography and then followed by contrast enhancement. And you see that the specificity and negative predictive value were 100% for hard masses with hypoenhancement or for soft masses with hyperenhancement. And only 20% of the patients require most probably US. So you can, USFNA. So you can use this kind of information to select your needle. So if you want to use only cutting needles, then it's okay, but you will spend a lot of money. So then you can look at elastography, you can look at contrast enhancement. If you have a hard mass which is hypoenhanced, then you can use the unusual 25-gauge cytology needle because it's most probably an adenocarcinoma. Again, in the other situation, if it's hyperenhanced and it's soft, then you'll, if you want to prove that it's chronic pancreatitis, then you will use a microhistology or a cutting needle. So you can use this kind of algorithm to select your needle because nobody knows which needle to use. So everybody picks a needle, it's either a 25 gauge or a 22 or a 19 or a cutting needle. So it depends on how much money do you have and how much money do you want to spend. But this is a way of, let's say, saving some money. If you look at the guidelines, there is a specific guideline for contrast, for all types of contrast, but looking specifically for the pancreas, in solid pancreatic lesions detected on ultrasound, contrast can be used to characterize ductal adenocarcinoma. So this was first recommendation. Then it can help you distinguish from in between pancreatic ductal adenocarcinoma and neuroendocrine tumors with pretty high accuracy. And it can be used to define the size and the margins of a pancreatic lesion whenever you don't have a clear image on grayscale. And just a brief mention on confocal laser endomicroscopy. So you probably know that it can be used through a needle, and the initial images were pretty nice. So the resolution is quite high. So you see the fiber here was placed through a needle, but we kept the fiber only in the duodenum, so on the mucosa. So you see very nice images with microvilli. And you even see the microvascularization, you even see the erythrocytes flowing. But this again, this is duodenal mucosa. And we try to apply this in pancreatic masses. The initial images were suggestive of histology. So this is normal pancreas, this was chronic pancreatitis, this was adenocarcinoma with pseudoglandular structures. And we've tried to find a correspondence. So this again is normal pancreas with some erythrocytes flowing here in a vessel. This was a pancreatic adenocarcinoma. So the images are really nice. The problem is that you don't get this kind of nice pseudoglandular images in all the patients. And that was one of the problems. You can, of course, find a correspondence with pathology. So we thought we had a correspondence on pathology. But then this study, I think, ended the story of endomicroscopy. I think John is here in the room. So at least for solid focal masses, so we looked at 28 patients with various NCLE parameters, and you see that the sensitivity, specificity, and accuracy for NCLE range from 19 or even 0% to 50%. Or so it's even better if you throw coins for all the parameters here. So and the inter-observer values range from 0.2 to to 0.4. These were novice examiners, and they were even worse for experts. So the conclusion was not very positive. At least in our hand, it was really difficult to get images. So maybe it's easier with cystic masses. So that's the Royal Castle in Romania. That's in grayscale. So I hope you are appreciated better in colors. Thank you very much.